Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 45, Birth After Caesarean. This is another episode that's been simmering in my mind for a long time. If you've listened to episode 8, Motherhood Part 2, you will already know it has a specific personal resonance for me. I've made a conscious choice to call this episode Birth After Caesarean, with no preconceived ideas about what that birth might be. With the rising caesarean section rates in the last couple of decades, and with the average family size being 1.9 children in the UK, we are seeing increasing numbers of women for whom considering their birth choices after a caesarean is a reality. We've departed from the saying, once a Caesar, always a Caesar, because the reality is that doesn't hold true anymore. This saying was on the basis of what we call true cephalopelvic disproportion. And actually, the number of caesareans done for this reason are extremely rare. For this to be true, it means that the baby's head is too big to fit through the woman's pelvis. And for us to make this diagnosis, the baby's head doesn't descend normally during the progress of labour into the pelvis, despite it being in the optimal position, the occipito-anterior position with the baby's back at the front of the woman's abdomen. When true CPD exists, then yes, a repeat caesarean is required. But what in reality we see is what's called relative CPD. That is, the baby's head doesn't descend and come through the pelvis because of the position the baby's head is in. Perhaps it's back to back, or perhaps it's transverse. It hasn't rotated correctly. And so actually, if that woman has a similar sized baby but in a good position, the outcome, the birth, might be very different. If you look at the advice from the Royal College of Obstetricians and Gynecologists, there are, in fact, relatively few situations in which a so-called VBAC, vaginal birth after caesarean, is contraindicated. This means an antenatal period examining the woman's options and priorities and looking at her specific individualised information is important. Giving her a choice determined by the woman, hopefully choice not influenced by bias in information provision from health professionals. This is a thorny issue. We need to understand that what we accept as a risk and what the woman accepts as a risk may be different. As obstetricians, our main fear is a bad outcome, scar rupture, the scar on the womb opening up during pregnancy or labour. If a woman is in spontaneous labour, that is, her labour has started naturally and she's had a caesarean birth before, the chance of this scar rupture is rare, 1 in 200. and the chance of her baby being admitted to the neonatal unit and the chance of her needing an emergency caesarean is actually not that different from any woman having her first baby and her first labour. Embrace, who run the UK Obstetric Surveillance System, or UCOS, looked at the frequency of uterine rupture and found a risk of 21 per 10,000 women for women with a previous caesarean scar. So, whilst it concluded that uterine rupture is a significant complication and may have a serious adverse effect on both the mother and the baby, it's very rare. So if the risk of a woman having a vaginal birth after caesarean in labour is similar to that of a first-time mother having a labour, why do we obstetricians get so fearful about it? Sometimes we're in a situation where we doctors can take it upon ourselves to rule out options that a woman may wish to consider. I may be unpopular in saying this, but it's truthful. We can try and individualise the woman's risk of complications. For example, we know women that have a short interpregnancy interval, so a short time between having a caesarean and getting pregnant again. A short interpregnancy interval of less than 12 months means she has a slightly higher chance of scar rupture and an increased chance of needing an emergency caesarean. For some of my colleagues, having a short interpregnancy interval will mean she must have a repeat caesarean. Instead, I prefer to talk to the woman about what her priorities are and what the data shows. It doesn't mean she can't have a vaginal birth after caesarean, but it does mean that she needs to be aware of the increased risks if she goes into labour. We can help her try and manage those risks by monitoring the progress in her labour, monitoring her baby's heartbeat, looking for any signs of rupture so that we pick up signs or symptoms early and act accordingly to try and keep her and her baby safe. But it doesn't mean that she couldn't try if she wishes to, if she feels that those risks are acceptable to her. I have a particular interest in exploring birth and experiences of birth, and for some years I've been running a birth options service alongside specialist midwifery colleagues. I try and listen to a woman, provide her with information relevant to her. Some is quantitative, evidence-based, and some is best guess, but being open and honest with her about which is which, trying to create an individualised risk. I've done quite a lot of reading around the subject to try and look at predictive models to try and help inform those conversations, making a plan that has fluidity, flexibility. You can't exactly give a woman a risk or a chance of her vaginal birth after caesarean being successful, but you can give her some good information. There are definitely things that we know are positive predictors. Perhaps her previous caesarean section was for a breech baby. Those women have a good chance of a vaginal birth after caesarean, as do women who've had a vaginal birth before. But for a woman who's had an obstructive labour, maybe has a bigger baby, maybe needs timing of delivery because of complications in her pregnancy, such as gestational diabetes or raised blood pressure, her chances might be lower and her risks might be higher. When we're having these conversations, there used to be an excellent NHS shared decision aid. Yep, I know, shared decision aid's not necessarily the best terminology because it's the woman's decision, but the practicality of it was really helpful. You could use it to think through what priorities that woman had and weigh up, therefore, what she might want to do. It had pros and cons of each decision in different columns, and the woman could tick off what were the things that were important to her. Was it important for her to plan birth, the timing, that is? Or was it important for her to feel that her baby came when it was ready? What was her preference? The certainty of a planned caesarean over the possibility of an emergency caesarean. Our expectations are based on how she's been in her previous pregnancies. If she got into the late stages of labour, she will labour like a second-time mum, whereas if she never established labour with the caesarean baby, then she will labour like it's her first baby. So her expectations about how long she might be in labour and what that outcome might be are quite different. Similarly, if a woman is having a first vaginal birth, having had a caesarean before, when she's making her choices, it's important for her to understand that assisted vaginal birth is an option. It's not fair to compare a straightforward planned caesarean birth with an uncomplicated vaginal birth. Those are two options, but there could be an intermediate one of assisted vaginal birth, plus the outcome of emergency caesarean section. And I hesitate to call it an emergency. Most caesareans done in this case will be within the next couple of hours and in a calm fashion with the woman awake, with no detriment to her or her baby. But we still know that a caesarean in the later stages of labour may be more complicated for mother and baby than if she'd had a planned caesarean in the first place. It's also important for women to understand what the implications are for any future pregnancies and future surgery that a woman might need. What family size does she want to have? The more caesareans she has, the more complicated her future pregnancies might become, with increasing risks of scar rupture, problems with her bladder and bowel due to scar tissue, and also placenta accreta, a rare complication where the placenta implants into the wall of the womb is much more common the more caesareans a woman has. I always suggest that women should have several plans, a series of birth plans. This is my plan A. This is what I'm planning to happen. And this is my plan B, my contingency plan, if that doesn't go to plan. For some women, the right option is a repeat caesarean section, a so-called elective caesarean, planned. This might be planned at 39 weeks because that's the best time for the baby. Before this, a baby born by caesarean has a higher risk of breathing difficulties due to the fluid in its lungs that have not been expelled by contractions and the journey through the birth canal. Some women want a planned caesarean but want to wait for their baby to be ready. For some, they prefer to have their caesarean when some contractions have started. Or they may want to book their caesarean for 40 or 41 weeks and feel that their baby comes when it's ready. We can be completely flexible with this and accommodate that woman's wishes, providing she understands that the later the caesarean is booked for, the higher the chance of her going into labour beforehand and what the implications of that may be. Breathing issues is one complication that we know can happen when a baby's born by caesarean. But there are other unknown quantities. We know that the microbiome, the bacteria on the skin of the baby, are different if the baby's born by caesarean than if it's born vaginally. But we don't totally understand what impact that may have. We think it may have some relationship to the later on development of asthma and allergies in that baby, but we don't know how to correct it. We don't know what the consequences are. In the same way I mentioned once a Caesar, always a Caesar, we've changed in our attitudes to women who want to try for vaginal birth after 2 caesareans. It used to be commonplace that any woman that had had 2 caesareans was recommended to have a 3rd caesarean. And this is certainly still the case for some obstetricians. However, if you examine the RCOG guidance, it seems that the risk of scar rupture for women having a vaginal birth after 2 caesareans is actually no higher than if they have 1 caesarean. When you look at the absolute indications or contraindications for VBAC, it says 3 or more previous caesareans in its list. Taking things pragmatically, it depends why she had the previous caesareans. If she had the caesarean because the baby was breech, and then a caesarean because she didn't go into labour and was overdue and didn't want an induction, then actually she's never laboured. And to try for a vaginal birth if she goes into spontaneous labour may well be a very reasonable plan. There's no suggestion that this woman's labour will be dysfunctional or difficult. If, however, the woman's had a caesarean because of possible recurrent reasons, perhaps the labour was obstructed in both cases, then the risks of undertaking a vaginal birth after 2 caesareans may be quite different. Once again, one can have a practical conversation with a woman about what are her chances, what are the pros and cons, what are the possible outcomes, and what does she feel is most important to her. Some women, having had difficult interactions with obstetricians, will choose to undertake their vaginal birth after caesarean at home or in our birth centre to prevent unnecessary intervention. Whilst this wouldn't be our recommended practice because we would normally recommend continuous fetal heartbeat monitoring, it can be an extremely valid choice, particularly when you consider what I said at the beginning of this episode, that we can be risk averse, we can be hesitant. We obstetricians can be anxious about a woman labouring when she's had a caesarean before, and that can lead us to intervene perhaps too early, erring on the side of caution, rather than necessarily giving her the chance to go with what her body's doing. It's a tricky balance to maintain safety alongside allowing nature to take its course. When I have a woman who wants to have a home vaginal birth after caesarean, I need to examine carefully why she had her first caesarean, what were the reasons, and is it likely to be a recurrent problem? If she had a large baby and gestational diabetes, these are likely to be recurrent issues, and with the best will in the world, unfortunately, that is not as safe an option as if she had a caesarean because of distress in the baby, which is a non-recurrent issue. Because I work very closely with our consultant midwife and our home birth team, I can confidently discuss with women the chances of their vaginal birth after caesarean at home, and know that the home birth team will transfer the woman in if they have any concerns at an early stage, so we can mitigate any chance of any complications. Building that rapport with women during their pregnancy is critical to safe care in these situations. It's all about threshold of risk, our threshold of risk, and the woman's threshold of risk, and trying to align those, make sure she's had the information and her partner's had the information to take the relevant decisions. Some women, when they come to my clinic and we discuss their options and their rationale for why they think the way they do and what they're planning, I can completely get on board and understand where they're coming from. We can have a sensible, rational, adult conversation. I can support them with their choices, but at the end of the day, it is their choice. And we need to leave our biases behind. We've tried to overcome this where I work with the introduction of the Emerald Team. Emerald Team are a group of midwives specifically looking after women with previous caesarean section. They're our first continuity of care team. The idea behind it was knowing your midwife, developing that relationship, and them getting to know you during your pregnancy would mean not only that women would be confident and well counselled and understand their choices, but also that when they're in labour, they would be well supported by midwives with expertise in this specific clinical situation. The Emerald Team midwives have training that I've organised where we discuss the risks and benefits, the predictive things that we might use to help a woman decide what her individual risk is. And we work closely with monthly team meetings where we can discuss cases and the midwives can ask my opinion. I can see women for some of their appointments to support the midwives, but if things are straightforward, they will receive midwifery-led care as their only risk factor may be having had a previous caesarean. Our aim at the end of the day is for a woman to have a positive birth experience. That might be a planned caesarean. That may be best for her, her baby, and her growing family. But for others, it might be an attempt at vaginal birth after caesarean. And it's been fantastic to see some women regain confidence in their body and their ability to birth their baby after perhaps a very difficult previous birth experience. For some, this can be extremely cathartic and reparative, and they can feel a tremendous sense of achievement when they birth their baby vaginally. For others, their labour may end in an emergency caesarean, and they may feel that this was the right ending for them at that point in labour. They will have been given choices throughout about how long they want to wait for contractions, and if at any point they feel that they don't want to continue, they can opt out. For some women, inevitably, birth will not work out. They will have an emergency caesarean and feel that they wish they'd had a planned one. Or they may have an assisted birth and a tear, which they end up feeling, again, that would have preferred a planned one. You will never end up in a situation where everything is perfect. But with the support of the midwives from the team through into the postnatal period, hopefully that gives a chance for women to discuss, debrief and process their birth experience, however it's turned out. One difficult issue can be if women don't go into spontaneous labour. We give them choices about induction or not. The reason I mention this particularly is some methods of induction with hormonal treatment can increase the risk of scar rupture, as well as reducing the chance of successful vaginal birth. We've started to use mechanical methods of induction, small rods called dilapam that we can put through the cervix that swell up and open the cervix a little bit so that we can break the waters. A woman may only have a 40 or 50% success rate of having vaginal birth with an induction, but for her, that may be preferable to the certainty of a planned caesarean. She may or may not feel comfortable having syntocinon, the hormone that induces contractions, as this carries a slightly higher risk of scar rupture, around 1.2% versus 0.5% if she labours spontaneously. Once again, the choice is hers. When she's overdue, we can give her a choice. She can book a planned caesarean. She can think about induction and what parameters within that induction she would like. Would she like her waters broken? That doesn't mean she has to lead on to having a hormone drip if she doesn't want to. She could have a caesarean if labour doesn't start. Or she could have a time on the hormone drip to see if we can get her into labour. The alternative, of course, is to wait longer for labour to happen. Sometimes I'll do a late growth scan to look at the well-being of the baby, and possibly if a woman is waiting beyond 42 weeks, I'll institute some fetal heart monitoring to try and assure myself and the woman that the baby is doing well while she's waiting. If a woman needs induction earlier for other reasons, such as gestational diabetes or blood pressure, it's about weighing up the pros and cons. What's the downside of the pregnancy continuing that little bit longer and giving her body a little bit more chance to go into labour naturally, and therefore a lower risk of a problem with her scar in labour, versus the induction process, which may be more likely to end up in an emergency caesarean? And therefore, does she want to opt for a planned caesarean? Women change their minds multiple points in pregnancy, in my experience. They often feel very strongly at the beginning of pregnancy and fluctuate their opinion over the course of the pregnancy, and then firm up a decision as they get a bit closer to their due date. As birth approaches, it often focuses the mind. Even then, some women change their mind right up to the last minute, and we can accommodate that. A woman might be admitted for a caesarean and decide she actually wants to have her waters broken. Some women will push back the caesarean date and decide they want to wait a bit longer. Some women will feel that they need to bring it forward, that actually they're not comfortable waiting that long. In the modern era, we believe a lot in choice. Choice so that the woman can decide what she wants to do. And that is absolutely right. But I do have some women sometimes who say to me they're faced with too much choice. Actually, they find the information overwhelming. Perhaps they want our advice about what we think they should do. Or they don't want the responsibility of that decision. I've had women say to me, I don't want it to be on me if I make this decision and then something happens. And that's difficult. We're moving away from paternalistic medicine where we tell people what to do. And I will give people my advice. Sometimes I'll say, from how you're talking, listening to you, hearing your thoughts, I think maybe this is what you're leaning towards. And I will suggest sometimes they try on decisions. So I may say, I think you're saying you'd prefer a caesarean. We can book a caesarean, and if that sits right and you go home and feel relieved, that's fine. And if you go home and you feel, no, I'm not sure about that, we can change that decision. Sometimes it's the opposite. I'll say, let's leave it open. Let's see how you feel. Let's wait and see if you go into labour. And then they might ring up a day or two later and say, no, actually, having thought about it, I'm now worrying about it. I want to book a caesarean. So sometimes trying on a decision can be helpful when a woman just feels like there's too much to think about. So the most important thing for me is that a woman feels confident and comfortable with the decision she's made. That way, she'll be ready to welcome her new baby, however it arrives. For today's zesty bit, I want you to be open-minded. I want you to leave behind your prejudices, your concerns, your biases, and your worries about risk. Think about the individual assessment of the woman in front of you. What are the benefits of labouring for that woman and her baby? What are the benefits of a planned caesarean for that woman and that baby? Ask her what her priorities are. Ask her what's important to her. Find out what's her home situation. Does she have lots of flights of stairs? Has she got a supportive partner? Is she a single parent? All these things may factor in how she feels about her birth options. Read and explore some of the links I've put in the programme notes about how we might individualise a woman's chance of successful vaginal birth after caesarean. And I would urge you to read Michelle Quashie's account, Strong Since Birth, of her vaginal birth after 2 caesareans and her home birth after 2 caesareans. Sometimes as medical professionals, we can intervene, scaremonger, and put someone off, when actually, if we were supportive, we could help her do what her body has always been destined to do. If you're a pregnant woman listening to this and you've had a caesarean, I hope I've given you some food for thought in thinking about your future births, and again explore the links and work with the team looking after you, your midwife, your obstetrician, to figure out what is the right birth for you and your baby this time around. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FWmaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.